Hi, everyone. Welcome to this webinar, Striving for Mental Wellness in an Unequal World. I'm Shayni Geffen, the project leader of advocacy and awareness for the South African Federation for Mental Health. It's an absolute honor to firstly welcome you here today, and secondly, to moderate this conversation. We have colleagues joining from all around the world, including countries where we're facing some very serious challenges at the moment. So right now in South Africa, we currently have rolling blackouts or load shedding, where our electricity is cut off for 2 hours at a time for multiple times a day. And I mentioned this to say, firstly, please bear with us if any of our speakers' internet connectivity may be a bit weak. And secondly, as an example of how, even though we might all be attending the same webinar, being able to connect has not been easy for everyone. I know colleagues who woke up extremely early and then traveled to friends' houses to be able to connect to internet. I've got colleagues who are connecting from their cell phones instead of from their laptops. And then there's some people who weren't able to connect at all. And I'm sure that you can see where I'm going with this analogy. You know, this past month, we've spent a lot of time reflecting on inequality to access, and specifically inequality to accessing mental health care. However, to address inequality in mental health, we just have to address inequalities, full stop. And today we host this international panel where we have experts reflecting on inequalities as well as what we can do to overcome them. For those of you who've just joined, welcome. It is really, really great to have you here today. To start us off, I would love to introduce Steve Appleton and Professor Lesley Robertson. Steve is the Europe Regional Lead for the International Initiative for Mental Health Leadership based in the UK. And Lesley is a psychiatrist and adjunct professor in South Africa. Both Steve and Lesley have trained as clinicians, Steve as a social worker in the NHS in the UK, and Lesley as a psychiatrist working with communities in South Africa. And so the first question to really kick off this webinar is, Steve and Lesley, how can mental health professionals work with other partners to help reduce inequalities in mental health service provision and help better protect the socioeconomic rights of people with lived experience of mental health conditions? Steve, perhaps we can start with you. Please feel free to turn on your camera and unmute yourself.
Thank you, Shayni, and good morning, good afternoon, or good evening to all of you, wherever you happen to be dialing in from. It's a great pleasure to join the South African Federation for Mental Health webinar today, and congratulations to Shayni on bringing this together very, very quickly indeed, actually. Most of these things take weeks and weeks to organise, and this has been put together very swiftly. So as Shayni said, I'm Steve Appleton. I'm currently the European Regional Lead for an organisation called the International Initiative for Mental Health Leadership. We have 10 member countries and 4,500 individual members around the world. And our aim is to advance, knowledge exchange and leadership development in our countries. The question really about how to bring mental health into the centre of thinking in a way that can challenge some of the inequalities that exist, both in terms of mental health service provision, but also, just as importantly, the determinants that affect poor mental health, I think is one of the most significant questions of the moment. And really, I think our experience as an organisation around the world is that a cross-sectoral approach is one which reaps benefit. And what do I mean by that? It's a very kind of jargonistic word, isn't it? Cross-sectoral work. Really what it means is trying to help other organisations to understand and take account of mental health in all that they do, in their policies, in their operations, and thinking about some of those wider factors, which might be things like access to safe and affordable housing. It might be about how people with mental health problems are able to gain access to meaningful paid employment. how people who are in employment have their mental health needs responded to by their employer, how other departments of government really think about the effect of what they do on people's mental health and thinking about accessibility. You've already touched on issues of digital access, and digital connectivity has been fantastic throughout the COVID period in enabling people to stay connected. But many people around the world simply don't have access to digital technology, whether that be they can't afford the hardware, they can't afford the connection through broadband, or that connection, as you already pointed out, can be particularly unstable and doesn't reach all parts of the country and all members of the population. So there's an issue around accessibility there. Things like public transportation, how do people get access to go to places to receive services when they need to? And ultimately, I think this becomes an issue that a colleague of mine has described as being hyper-local. So you can have central government policy and you can have regional government policy, but it boils down to what happens in communities and how we as professionals, and I speak as you referred to my training as a social worker. I should confess it's a long time since I practiced as a social worker, but those values are still strong. And I think that's about how you work with individuals and communities to really come together and respond to their needs and allow communities the opportunity to tell us as professionals what it is that they need, not for us to impose solutions upon them from on high, and to really work alongside them, include people with lived experience in your thinking about the ways in which you can respond. And I suppose finally the thing I would say is really about how you can find ways to connect different sectors with communities, but to do that in a coordinated way, and by focusing on prevention and promotion and population mental health, you can not only have an effect on those things, but you can have an effect on services themselves, in that you can enable those services to focus on working with people with serious mental illness, because that's what those services are predominantly about. And no doubt Lesley will touch on that in a moment. So a rounded approach, working with all sectors, working closely with communities. There's lots of evidence out there, but a real focus on promotion and prevention is critical.
Wonderful. Thank you so much, Steve. Lesley, over to you.
Thank you very much, and good morning. And as Steve said, good afternoon or good evening to everybody. And thank you very much, Steve, for kicking this conversation off. And I'd like to take it up where you've left off, that what we needed is this rounded approach, working with all sectors, working with the communities. And I think for me, the biggest problem is we're not trained to do that. So in South Africa, our training of mental health professionals is very much disorder orientated. It's not community orientated. It's not outcome-based orientated. It's really learning about the pathology of the disorders and then the theory around the treatments, and that's what we implement. So if we want to make, or how can mental health professionals work with other partners, we've got to change the way we think of ourselves as mental health professionals and our disciplines. We've got to see, and this has to impact on the way we train our next generation of professionals. So in our training, for me, we really need to incorporate what each sector's role would be. And the mental health professional needs to know that. They need to know how to be accessible. Sorry. They need to know how to be accessible, how to be available to people of other sectors. So my experience as a community psychiatrist, and in South Africa, community psychiatry actually doesn't exist. There's a few of us who practice it, and we encroach on the primary healthcare budget in order to practice it. There's no budget for community psychiatry. And what happens to us is we have phone calls frequently from social welfare, from education, correctional services would love more input. And we don't have the time, the budget, or the expertise to really address their needs. So how we can work with other partners, which is what we need to do, is we need to have a person-centered approach to care and a person-centered approach to our training. What is the use of knowing all the pathology if we're not going to help the person's life improve? We then need to have a relationship approach to our practice, a collaborative approach, where we see ourselves as part of a network of equal partners whose goal is to improve the outcomes for the person with a disability, so that we can mitigate the environmental problems and hurdles that that person has to negotiate, as well as trying to treat sort of medically the disorder per se. So I think that is my final point.
Yeah. Thank you so much, Lesley. And thanks to both of you for really outlining how, through implementing this rounded approach in our training and in our practice, as well as integrating mental health across a variety of different platforms. We spoke about the tech, we spoke about the education sector. We will firstly be able to engage with what community needs are, and secondly, and ultimately reduce inequalities in mental health care. I think another strong theme which we've been hearing throughout this past month, but that also came up in both of your the way that what you were saying, is how we need people with lived experience to really be at the forefront of service design and implementation. And today we are honored to be joined by Marsha McAdam and Rademeyer, who are both mental health experts through experience and ambassadors for people with lived experience. Marsha is based in Manchester in the UK, and Dylan is based in South Africa. Both Marsha and Dylan serve in an advisory capacity to organizations based in their respective countries. Marsha and Dylan, so a question that I have for both of you is, if you were to reimagine what accessible mental health care looks like for you in your country, what would that look like? Marsha, perhaps we can start with you.
And thank you, and goeiedag, good afternoon and good evening. I was brought up in South Africa, so it's quite lovely to be here. I've seen the both sides of living in South Africa and living in England, where we have the free NHS. So I have both physical and mental health needs. I identify as having borderline personality disorder, otherwise known as emotional unstable personality disorder. For years, I was stuck in a cycle of self-harming, and on one occasion ended up in ICU, placed in an induced coma for 3 weeks, and then being weaned round in that for the other week. And it was only 2 years later that I received life-changing, but also life-changing, but also life-saving therapy called mentalization-based therapy. And it really helped me so much. But I'm so aware that, especially in my country, there's so much stigma attached to that label. One of the other things that I thought was, in England, we have the free NHS service. However, there's so long waiting times. We have for IAP, which is improving access to talking therapies. It's just a short 8 sessions, but that's just for anxiety and depression, really. What about the other ones, you know, the more complex needs? There's almost over a 2-year waiting list. And sometime when someone actually gets there, or just as the waiting time comes up, they're deemed as being too complex, not stable enough. So a lot of people now, I believe, are going private. I also have physical health needs and need domiciliary care. And so I receive benefits, but from those benefits, I have to contribute. It would be 1/3 towards my care per week. And then more recently, I have to contribute to bedroom tax because my son's moved out. So going forward, if I want to have a job, I have to earn £100 per week before all the other outgoings. So it's sometimes, oh, what do you do? Stuck. And then for me, co-production has given me purpose in life. I'm actually proud of something for the first time ever. And I will just say my co-production is I actually now, the person who created mentalization-based therapy, world-renowned Professor Peter Fonagy, I actually now work with him and Sarah Hughes, who's Chief Exec of the Centre for Mental Health, to do something around the stigma that comes with BPD. And that's how I know Steve as well. So thank you.
Thank you so much, Marsha, for firstly providing that UK context, as well as speaking of the value of co-production on so many levels, the personal one, the global one, in terms of informing the services that we provide. So thank you so much. Dylan, you are based in South Africa. If you were to reimagine the mental health care system, what would it look like?
Hi, good day, everybody. Thank you for having me, firstly. So if I had to reimagine accessible mental health care in South Africa, mental health services would definitely be more readily available. At the moment, there are not many mental health organizations or societies which provide free services. This definitely has to change. One would
apologies. I think that Dylan's internet connectivity might be a bit unstable, as discussed earlier with regards to the load shedding. So we'll wait 10 seconds to see if Dylan returns. If not, we will move on and then come back to Dylan, if that's okay. I think what we should do in the interest of time, to make sure that there is sufficient time for Q&A, we'll move on, and then we'll definitely come back to Dylan for him to share his thoughts. So just to say, well, thank you so much, Marsha, about those reflections, and looking forward to what Dylan has to add to that as well. At this moment, I would love to introduce you to Thilini Perera, who is the CEO of LifeLine International, based in Australia. Thili, LifeLine International is comprised of 19 countries as member states, and not all the countries in which LifeLine operates in have the same mental health, financial, and human resources, and can offer the same breadth of services. Can you please speak more about how LifeLine, which is an international organization, ensures that each member state, or the member states with less resources, are more supported in an effort to reduce inequality in mental health care provision globally?
Absolutely. Thanks, Shayni, and thanks for the opportunity to participate today and share our knowledge, but also hear about everyone else's experience. So absolutely, LifeLine International has 19 different countries that are members and deliver a range of services, primarily crisis support and suicide prevention services. And as you said, Shayni, we've got a range of members in the low and middle income countries, and then members in the high income countries. And really the goal is to share resources in a bid to try and reduce that inequality of services across those different countries. And primarily, we try to do that in 3 ways. Firstly, at the highest level, I guess it's around policy and regulatory and systems change. So partnering with our member states and our centers in country and people with lived experience and a range of stakeholders within a country to really advocate and have those discussions with government, for example, around a range of things. Firstly, it could be around the rights of people with mental illness and ensuring that they can actually access services. Secondly, advocating and empowering those centers to advocate to ensure that mental health is actually a priority in that country in terms of the public health agenda, because it's often takes second place or has no place sometimes in terms of the public health agenda. And in order for us to do something and get resource allocated to it, to the issues, we have to make sure it's a priority for government. So really partnering with people to advocate for policy and regulatory change that enables us to integrate mental health into primary care and into the overall health budget. Secondly, it's about ensuring there's funding and resource allocation and workforce and infrastructure available to support sustainable service delivery in those countries. And that happens in a range of ways. Again, advocating within, a region like, say, the South Pacific or in a country with a center involved around funding from government, not just the government of that country, but perhaps advocating for Australia and New Zealand, perhaps to fund some of those services in the South Pacific, because we all have responsibilities to our neighbours and to other people across the world that need access to services. But we also see that as a public-private partnership. So also doing our bit to bring our contacts to the table around, the business world and corporates that should be supporting services where possible and donating funds to enable that to happen, and not putting that burden solely on government to fund services, and really coming together in that public-private partnership and walking alongside those centres that don't have enough resources to pull together a funding application. We can step in and help with that to ensure there's those funding services available to centres. And finally, at a really practical level, it is like this around knowledge sharing, ensuring that we share our expertise, make sure there's access to training. We have this saying in LifeLine International, build it once and share it often, whether that's platforms or training materials or, access to just ask another country, what did you do when you encountered a sudden surge of service demand during COVID? How did you manage that? So we're not always reinventing the wheel from scratch. Where we can, we try and build it once and share it often. So through these processes, we try to ensure there's, we bridge the gap in terms of resourcing, prioritization of services, and empower other countries in that low and middle income bracket, particularly, to be able to deliver services.
Thank you so much, Thili. I mean, it's fantastic. I think these points of policy, sustainable financing, and really investing in human resources and adapting evidence-based practices to suit the local context, it really provides tangible points as to how international mental health organizations can support national branches. Dylan, I'm going to try return back to you. Fingers crossed the internet's working. Can you unmute and can you hear us?
Hey, yes, sorry about that. The internet is back on. Do you mind if I just start again from Elvis?
That's perfect. That would be great.
Fun. Okay, thank you. If I had to reimagine accessible mental health care in South Africa, mental health services would be more readily available. At the moment, there are not many mental health organizations or societies which provide free services. This definitely has to change. One would generally have to pay quite a bit of money if one wants decent mental health services in South Africa. Government would definitely have to play a big role in prioritizing mental health the way they should have been doing all along. They would open up centers dedicated to free mental health treatment. These centers would be accessible to people of all walks of life. The current government mental health services which are available are rather limited. There is often only one psych nurse or doctor allocated at government facilities. Also, we would have a society that speaks openly about mental health instead of hiding the topic in the shadows. Mental health would be incorporated as a subject at school level as to educate people from a young age about mental health. This would help in breaking down the stigma attached to having a mental health condition. South Africa's unemployment rate in general has hit a record high of 34.4% or 7.8 million jobless people. According to Statistics South Africa, the national disability rate is 7.5%, yet employees with disabilities make up only 1% of the workforce. Companies are by law supposed to employ 3% of persons with disabilities. In an ideal world, this percentage would be much higher, say around 20%. Stigma still exists in companies today due to ignorance. When applying for jobs, some companies ask whether you have a disability or not. One would suppose that this is for reasonable accommodation purposes, but this is often not the case. It is often used as a tool to discriminate. An example from my own experience is that once I applied to a specific call center and decided to disclose that I have a disability, about a week later, I received an email from the call center saying that unfortunately my application had been unsuccessful. I initially thought nothing of it. A number of months passed and I ended up applying for that same call center once more. This time I decided not to disclose my disability. Shortly after, I was contacted to go for an interview as I do have experience in the industry. This was the moment that I realized how real stigma is when it comes to employment. This is something that needs to change drastically. This can only be achieved if methods of educating society are put in place by government. In the meantime, persons with disabilities need to speak out and make their voices heard. Thank you.
Dylan, thank you so much. Hearing that story, I think was very powerful, and thank you for sharing your experience. And to you and to Marsha, just thank you. So we appreciate your guidance as to what is needed to really strive towards when we think about accessible mental health care, really being beyond just mental health service provision, but really in being in all other sectors of society as well. So wrapping up for these longer questions, I'd love to turn to Bharti Patel. Bharti is the National Executive Director for the South African Federation for Mental Health, based in Johannesburg in South Africa. And Bharti, kind of feeding in from what's already been said and on from Thili, who spoke at that international level, but speaking at a national level, how even within the same country, different people have very different access to mental health care services, and resources based on where they live, based on their gender, their class, their race, amongst other factors. In 2019, South Africa was ranked as the most unequal country in the world. The South African Federation for Mental Health is a national mental health organization in South Africa and works with community-based organizations throughout all 9 provinces in South Africa. So perhaps you could discuss, how do you see these inequalities in access out? Bharti, you're on mute. Sorry.
Thank you so much, Shayni. And, I must say, when Dylan spoke, I actually felt the hair on my hand stand up. And this is what is echoed every single day throughout South Africa. South Africa has made great strides in developing a human rights-based policy and mental health legislation. However, having these policies on paper does not guarantee access to mental health services. And due to an lack of an allocated budget, there is to some extent also a lack of political will, which has resulted in the mental health policy not being implemented by provincial governments. The responsibility for mental health services in South Africa is pretty much confined to the Department of Health, which results in a medical approach to treatment of mental health conditions. And this neglects the prevention and promotion of mental health to address the stigma and the discrimination. Also, a disconnect between the national and provincial departments of health has created greater inequalities in how mental health services are prioritized at the local level. Some of the provinces do not even have a mental health directorate. So mental health services are not allocated a budget, and we find situations where only 3 provinces have reported to have a child psychiatrist in the public sector. So child and adolescent mental health has been severely neglected. Adolescents diagnosed with a mental illness are detained for long periods in adult psychiatric wards, losing out on schooling. By the time these children turn 18, they are not equipped to enroll for tertiary education or even enter the open labor market. As you've mentioned, the South African Federation for Mental Health has 17 member organizations that provide community-based mental health social services in all 9 provinces. These are civil society organizations. They rely on donor funding to provide services like residential and daycare services, skills development, psychosocial counseling, as well as a statutory service, which is primarily the responsibility of the state. While they do receive minimal grants or subsidy for these services, the disparity in resource allocation between provinces results in an unequal access to basic mental health services like screening, for example. The minimal grants also affect the retention of skilled staff or personnel to provide services to the majority of the population. The disparity in salaries between government employees versus those employed by civil society organizations impact, this leads to a high staff turnover among civil society organizations, and it does impact negatively on the already stretched reach of services to the poor and the marginalized communities. Majority of the employees of civil society organizations are females who live in the same community where mental health services are provided. And very often these females have to go for months without pay due to the delays in payment of grants to civil society organizations. These employees themselves have families, especially children, whose livelihoods are also affected. So civil society organizations focus on marginalized, poverty-stricken communities already affected by poorly resourced schools, high unemployment rates, elevated levels of substance use, violence, including gender-based violence, which we know are contributory factors to increased risk for mental health conditions. It is these communities that have the least access to mental health care. We also find that rural communities have been neglected and that persons with disabilities have to travel long distances to access primary health care, where healthcare professionals have not been adequately trained on mental health, and medication is also not readily available. So our mental health system is in dire need of proper planning, implementation, and monitoring if we want to see an improvement in mental health for all our citizens.
Yeah.
Thank you.
Thank you so much, Bharti. Thank you. I think that just provided a really great overview about what it's like on a grassroots level, as well as nationally, what we can do to make more equitable access to mental health care services, support, and resources. I'd now like to open it up to our panelists for a quick rapid fire round. I would love to hear from each of you. What is one approach or resource or innovation that's being done in the mental health space that you see as playing a vital role in ending inequality? Steve, let's start with you.
Thanks, Shayni, and fantastic to hear from everybody, by the way. Some really interesting experiences and ideas. So thank you to fellow panelists and speakers. I mean, I think that there are probably a couple that I'd just briefly mention. I think the first is a movement that's happening in a number of different countries, and some of you will be familiar with it. It often attracts the title of Thrive. So here in the UK, we have examples of Thrive in the West Midlands, in London, down in Bristol, also up in Scotland, although in Glasgow it's Flourish Glasgow. And that's also starting up in Dublin, it's in Amsterdam, it's developing in Stockholm. There are a number of other examples. And essentially, that is a means by which you bring together a range of different partners to think about a population-based approach to improving mental health. And within that, that's thinking about the social determinants of mental health. And each of those programs is focused on particular issues, some of which I mentioned right at the beginning, that are specifically about trying to address issues of inequality in relation to access to services, but also the issues around stigma and discrimination that Marsha touched on, which are very broad in the sense of how they affect people with mental health problems. Another great example, I think, is the treatment in this country, in the UK, is the improving access to psychological therapies approach, in that it has broadened out access to a range of intervention that people just simply couldn't get before. And so while there are waiting times and challenges around that, as Marsha indicated, and it's for a very specific group of people, it has opened up accessibility around that. And thirdly, I think there's a huge amount of work happening in relation to workplace mental health, both in the UK and in Europe, but also in the Southern Hemisphere too. And one great example of that is some work done by a colleague of mine, Poppy German, who leads the City Mental Health Alliance. And that is a program that's about trying to improve awareness of people's mental health in the workplace, working with quite large businesses and other employers. A whole range of different tools that are developed and put in place within those employers who sign up to different ways of working. And I think that is simply about trying to address the inequality of people who either can't get work or do get it and then find themselves out of work as a result of their mental health problems because employers don't pay enough attention and often have discriminated against people and force them out of work as a result of their mental health problems. So I urge you to look at that work that's happening through the City Mental Health Alliance. We, as an organisation, work with them quite closely. So just two or three hopefully helpful examples.
Thank you, Steve. Super helpful. That's great. Lesley.
Thank you very much. So that's quite a tall order to follow on. And I think, so, I mean, I'm talking more from this perspective of South Africa, where mental health really has been, I mean, it's almost been actively excluded from healthcare. It's not that it's, we are spending money on specialized services and standalone hospitals, but as for community-based services, it's just non-existent, and there's no access to psychotherapies and psychological services. So what I think we've done, which has probably been the most far-reaching and in the health system, and which might pave the way for other middle-income countries, is we have a set of standard treatment guidelines. These are published by the National Department of Health. They are evidence-based guidelines. They are a local version which aspires to being similar to the British NICE guidelines. And we have integrated mental health guidelines into these alongside all other health conditions and in equity with other health conditions. The idea of these guidelines is that they're on an app, which unfortunately has crashed, so it needs a new app. But what once on the app, you can actually cross-reference. So if somebody is being treated for diabetes, there would be exclude depression or address depression and anxiety and a link to that. If they're being treated for schizophrenia, then there would be a link to diabetes because it is so much more common amongst people with schizophrenia. So I feel that these guidelines help quite as a tool for teaching undergraduates, for teaching all healthcare professionals. And they put mental health care on that same platform as HIV, TB, cardiovascular diseases, and so on. We have included in the guidelines recommendations for allied health professionals, as well as for lay professionals. So we've put in links for the Federation of Mental Health, for SADAG, our Depression and Anxiety group, and for Family Society of South Africa for lay counselors, so that we can try and start to encourage health professionals to utilize civil society organizations in the care of people who are presenting with anything, whether it's a mental health disorder or sexually transmitted infection, and then you find they've also got some kind of mental health condition. So my next big thing that I think is so far reaching is groups like the Federation for Mental Health, and to our advocacy groups that we have in our middle income countries. And I think they keep up hope. It's a constant battle. There's very, very little funding. I really appreciated, Thili, your presentation on how getting funding is such an important part of getting access. And they constantly striving for better mental health care, for better access, and for bringing people together, like on this presentation, you know, and for bringing people of all different groups together.
Thank you so much. Oh, sorry, Lesley.
Yeah.
Yes, super. Thank you. Thank you. Moving on to Marsha, just a reminder to our amazing speakers, just a quick 30-second, what is one approach, resource, or innovation? Just the one. There's so many to discuss, but hopefully we'll have time to go through that in Q&A. Amazing what's been discussed thus far. Marsha?
I would say for funding, recently our Chancellor has given us quite a lot of money for funding for NHS and that, but there's not staff, which is really worrying because we don't take care of ours. And then it's about co-production. If you invest in people, you give them purpose, but make sure that you remunerate them for their time. Don't take them for granted. Yeah.
Perfect. Amazing. Dylan?
Hey, so one innovation that I can say, like Lesley said, there aren't many community-based organizations which provide mental health services, but there is one here in South Africa, specifically in the Cape Town region. It's called Cape Mental Health, and they actually, especially now with the hybrid theory model that they're going with, they are actually able to reach a lot more people with a new hybrid model that they have developed. So it is possible for community-based organizations to have an impact in society. Yeah.
Super. Thank you so much. Thili?
Thanks, Shayni. For us, particularly during the pandemic, we realized we couldn't meet with people together because of restrictions. So we've been trying to scale technology, whether it's text, web chat, phone, apps, whatever it is, to reach more people proactively rather than waiting for people to come to us. So my thing is, let's try and use technology where we can as a scalable solutions to the parts of the world where we can to proactively make sure people have access to services.
Fantastic. Very, very important. Bharti?
Yeah, I think for us in South Africa, you know, the approach of actually costing mental health services, a holistic service. A study is being undertaken currently by the University of Cape Town, led by Professor Crickland. And I think, you know, that would really guide our government in terms of how resources can best be utilized towards equality in mental health. Thank you.
Thank you so much. Thank you, panelists. Thank you so, so much for sharing of your wisdom and your expertise. Before we move on to our Q&A, I see that Dr. Ingrid Daniels, who is the president of the World Federation of Mental Health, is also in attendance of the webinar. And perhaps I can just ask Ingrid to say a 1-minute message before we move into our Q&A.
Good day, everyone. Good morning, Shayni. Good day to all the delegates and honoured guests present this morning. It's a great honour to be part of this webinar, and I bring you greetings from the World Federation for Mental Health. I want to start off by just briefly thanking all the delegates and speakers in particular for raising and highlighting the multiple factors that impacts on the treatment gaps or lack of access to treatment and increases these inequalities across the world. For the first time ever, the world has chosen the theme, mental health in an unequal world. Together we can make a difference. And I believe that this is very significant. There's a clarion call that together we can make a difference. And I believe that the actions and the recommendations that are required will be ongoing. And they will go on beyond World Mental Health Day and beyond Mental Health Awareness Month, because these issues have plagued and impacted on the dignity and the right to access mental health for all. And so I wish you well as we continue in the discussion this morning and come up with solutions and actions to address these inequalities that have impacted on persons with lived experience of mental illnesses from living fully integrated, dignified and respected lives. Together we can make a difference. Thank you so much.
Thank you. Thank you so much, Ingrid. Perfect. I would now like us to transition into Q&A. If you have a question or a comment for any of the panelists, please pop it in the chat. If you would prefer to ask it in a very brief way, feel free to use the raise hand function and we'll unmute you. I know that there's been lots that's been discussed, so I'm sure that our audience has something to add over here. A message over here coming through from Matthew saying, great conversation, work being done in South Africa. Matthew Mutiso Coalition Action for Preventative Mental Health Kenya will be happy to establish collaborations and partnerships. That's great. If you also are looking to collaborate, I mean, the great thing about this panel is that it is international. Feel free to leave your contact details or your organization contact details in the chat, and then we'll be able to share that afterwards as well. Shauna, I see that your hand is up. Feel free to unmute and ask your question to a panelist.
Thank you so much, and congratulations to everyone. I think this has really highlighted the complex nature of mental health issues and therefore the complex answer we must come up with. I've been involved for a very long time in this world of mental health, and we keep talking about trying to change people's attitude, which would fundamentally make the biggest difference. And it's been mentioned that maybe we need to really educate children about mental health. And I know in relation to lots of other things, people have decided it's too late to change adults' attitudes. You need to impact on children. And I wonder if any of the speakers would like to comment on that.
Panelists, I'm going to open it up. If anyone wants to jump in here, feel free. Dylan, I know you spoke about the importance of educating children, so I'm not too sure if you want to elaborate more on that. Or Thili, yes?
Well, I was just going to share some of our experiences here in Australia, just generally around, you know, bringing that education approach to the wider public and to schools as well. But more specifically, it's been around suicide prevention. We've initiated gatekeeper training around Australia, that is to enable the community themselves to be able to spot the signs where possible and have a conversation around suicide prevention, or even on Are You OK Day to ask about mental health. And it's just about helping the community become its own safety net, because we recognize that services might not be able to get to everyone. So it's really important that we empower the entire community at large and educate them to spot signs and help get someone to a service or referral. But as a further step, we've also started doing things like Safe Talk in Schools, which is a program around suicide prevention that's being rolled out in schools. And we're looking at evaluating what the results are. So we'll probably know more in the future about how effective that's been. That's sort of been our experience at this end.
Super interesting to hear about that intervention that's taking place over there. Thank you so much for sharing, Thili. I can definitely see its applicability in the South African context and other contexts too. Thank you. Marianne, I see, I hope I'm pronouncing your name correctly. Please feel free to unmute.
Hi, thank you, Shayni, for the opportunity. I come from a background of positive psychology, which is very often focused in developed countries, and we don't hear much of in South Africa. I think many times people think it's something akin to Maslow's self-actualization, which doesn't apply when basic needs have not yet been met. But I'd like to suggest, and I'd like to hear what the panel has to say about it, that these massive systemic problems we have with access to treatment and care for people struggling with mental health generally, that is one part of the puzzle. But then another part of the puzzle is building the resources we do have. Now in South Africa, we struggle with access to resources. People struggle, they don't have access to the funds to pay for the resources that are available, because most often you have to pay for whatever service you're looking for. But I hold that, and I believe strongly that the individuals we have in our country, they are their most important resource. I believe that if we can spend some energy on building up individuals as resources, then we can move beyond just treating symptoms and ill health and move towards building resilience and wellness, not just the absence of mental illness. And one way that I believe that this would be possible is to introduce the concept, these positive psychology, these research-based strategies to build well-being in schools, in textbooks, which is something I feel quite strongly about, and also in tertiary institutions and also in the workplace. Thank you.
Great. Yeah, thank you so much. I don't know if there was a question there as much, but I'm sure that Lesley or anyone else from South Africa or from our collaborating international partners would like to add on to that point. Lesley.
Yes, I think that's an excellent point. And I think one of the biggest problems that we've got is that we're completely focused on the biomedical in South Africa, and our treatment is failing because there is no resilience development. So there's the resilience of the individual, which we should be harnessing. And just the fact, I'll often say to my young doctors when they have somebody who might be extremely uncontained and they want to commit him into hospital involuntarily. And I say, but hold on, he's come in voluntarily to the clinic. He's asking for help. And that shows us already that he has some internal resources. And the other one is the people around him, around our patient, because we know that if we could just have more social cohesion and more social support, we can start reducing all our meds, which, if so often we're prescribing to treat an environmental problem than anything else. So I think, Marianne, that is so important. Already what gets us through in South Africa is our internal resources and our resilience. That is what we're known for. That's why we can immigrate so easily, is everyone wants a piece of that. And people with psychosocial disabilities have a lot more resources than they think they have. And I think that is a key message. So thank you.
Thank you so much, Lesley. Thank you. In the chat over here, we have Mastura saying, I think we need to change the curriculum and add mental health education as a subject and have enough workshops to equip educators about mental health, because believe it or not, a lot of people, including educators, aren't educated about mental health. And I think that this is something that is very, very prevalent. I mean, you also hear cases of people, of mental health practitioners or health practitioners in the healthcare sector also just needing that additional training or upskilling in mental health as well. So definitely across all sectors there. Lungile says, excellent, interesting presentation on mental health. Thank you, Lungile. As a occupational health nurse practitioner in South Africa private sector, is there training or an institution that provides training towards becoming a clinical program coordinator in mental health? I personally haven't heard of this term, but I'll defer to Lesley, Bharti, if you've heard of this before.
Hi, thank you, Shayni. No, I know at one stage we had clinical or psychiatric nurses, but I recall Lesley advising that that doesn't even exist anymore because our nurses are trained holistically on mental health within the primary health setting. But it's a great suggestion, and I think it's something we can, you know, advocate for if that doesn't exist. I'm not sure in the private sector whether there is certain trainings that could be available, but not that I'm aware of.
Can I suggest something? So in our country, we have mental health first aiders, and I think it's 2 days, which is really intense, especially when someone's up against it in work all the time. But we're seeing that more and more, that we have dedicated mental health workers in various companies and organizations.
Thank you so much for sharing that, Marsha. I think one of the beauties of an international panel is that we can say we don't have that here, and then we've got another country come in and say, okay, we saw that, how it unfolded here, and this is what we did. And then for us to think, okay, what would that look like to apply it in our context? And it goes back to what Thili was saying. Thili, can you just repeat the LifeLine motto once again?
The build it once and share it often.
Build it once and share it often. I think that looking towards what other countries are doing, what other communities within our country are doing, how we can adapt those principles like mental health first aid training, see whether we can get that started over here, is exactly, it should be a product of these types of international collaborations. So thank you so much, Marsha, for sharing. I'm going to end off on this one question, which will hopefully be quick, and then we'll wrap up. It's from Gaynor saying, I'm a school counselor in Gauteng in South Africa and need a way to educate and inform our teachers and learners on mental health issues. Is there a supply of brochures, stands, etc. to use at our schools, preferably in hard copy, as printing facilities and funding is limited? Raising awareness is crucial as at our schools. And I couldn't agree more, and perhaps this is an opportunity for me to plug the organization that I work for and that hosted this webinar, the South African Federation for Mental Health. Okay, no, please feel free to reach out to us. We have those hard copies of brochures about a variety of different topics that relate to mental health. And we would be more than happy to connect and collaborate as to how we can best support you in championing mental health in the school that you serve. So with that, I would like to take this moment to thank all of our panelists for presenting and sharing their knowledge today. I'd like to thank all of you for attending. We encourage you to continue this collaboration, this dialogue. If you have any other questions, please feel free to reach out to myself. This recording will be made publicly available after the webinar. And thank you so much and have a good day further. Thank you. Take care, everyone.
Bye-bye for now.
Bye-bye. Bye.
Bye.
Thanks, Shayna. Thanks for the invite. Thank you.
Thank you so much. Thank you so much for attending, everyone.
Thank you.
Thank you so much.
Thank you. Thank you for your question, Jana. Thank you so much.
Well done.